Want to start?
Sure.
So what I'm going to do is you control the screen and you just share your screen, so it'll give you the option to so you can get everything ready.
Okay. Let's see my entire screen.
Or you can just show your app.
Oh, gotta click that. Okay. Can you guys see my screen?
Yeah.
Okay, excellent. So I've got 3 cases. The first one is a 20-year-old male, relatively little medical history, just some anxiety, and then intermittent chest pain. And he was vacationing in China and got this chest CT. Can you guys see the chest CT?
Yep.
Okay, excellent. So we were asked to reread the chest CT, and kind of a surprising, interesting pattern that I hadn't ever seen before, and was hoping for some thoughts. For us, the most striking things were that it was so subpleural, and these kind of cystic changes, but not really much else in the lungs. You can see that they're, if we look at the sagittal, that they're really following the fissures, very, very, very strikingly subpleural, pretty small, but relatively uniform in size.
So, Brian, I've seen this before in young people, and to me it looks like paraseptal emphysema.
Yeah, that's all it is.
Yeah. And
in a 20-year-old non-smoker?
I've seen it in non-smokers, and I've seen it in a patient with sarcoid. I don't know if they were true and unrelated.
Huh, interesting.
Yeah.
The first thing I was looking at was the skin. I've seen it. This is a good look in neurofibromatosis. But he doesn't have it. He doesn't have any skin lesions. But that was the first thought I had.
No, he does smoke marijuana. But we live in Oregon, and a lot of people do smoke marijuana. But that's great. Yeah, I think we put cool.
Yeah, this is not that uncommon, and actually, there's reports of this occurring specifically in people who smoke lots of marijuana. We have a lot of cases from the JPC showing this specifically in people who smoke marijuana. No one's really sure why, and I've seen it
with the deep
honestly
inhaling.
A lot more. I'm sorry.
You think it'd be something with the really deep, like intense inhales?
We thought about that too, and we were trying to see if it's different between people who like vape and do the smoke other methods, and unfortunately that hasn't turned up any effects, but or differences. But yeah, sometimes it's so much more extensive than this, and it's really striking. But yeah, that's what this is.
Okay. Another thing that I remember is 2 years ago, maybe 3 years ago, when I was at the RSNA, by random chance I came across an exhibit from a group at the NIH. And they showed a bunch of cases with subpleural cystic disease exactly like this. And they were speculating, because some of them had some weird genetic syndromes, because they have a genetic diseases branch at the NIH of unusual genetic syndromes. They postulated that it may be related to some of these genetic syndromes, but the only thing I remember about the genetic syndromes was that I had never heard of them. But they postulated in their exhibit that there may have been an etiologic association between the subpleural cysts and those genetic entities, which I had never heard of. So I'll try, if you like, to try and find that exhibit, because I don't think it was a poster rather than a computer-based one.
Okay.
That's my best prediction. But when you show this, it was exactly what they showed in about maybe half a dozen cases of strange genetic entities.
Great.
But there you go.
Awesome. So the next case is another young person. This is kind of an incidental finding on a CTA being done for GI bleeding in the setting of ulcerative colitis. And there was an anomalous artery arising from the aorta and going to the right lower lobe, but really no parenchymal changes in the right lower lobe. So just curious to hear your guys' thoughts about the spectrum from could this be an aberrant bronchial artery versus sequestration where the parenchyma just looks normal?
We call this probably systemic arterial supply of the lung, and it can occur like, in this case, I think it's just an isolation. It can also be part of a sequestration, but can you show the lung windows? Yeah, you can see there's no sequestered lung, and sometimes they can get hemoptysis from these because they're high pressure, and sometimes the lung is a little denser down there because of the overperfusion, but I think that's all it is, and it's a sort of a don't touch lesion.
Interesting. Okay. And then last case, this other kind of congenital lesion. Seen a few of these. Not sure what to make of this kind of outpouching of the posterior aspect of the left atrium, where the left lower and the right lower lobe inferior pulmonary veins kind of insert a little bit more inferiorly and posteriorly than the upper lobes that you can see here. Seen this a few times. This guy happened to have also this chronically elevated right hemidiaphragm, and we weren't sure if that was, we thought that might be related to this appearance as well.
You can imagine how, sorry, David, go ahead.
Is this a variant of core triatriatum, do you think?
Or I was going to say, you can almost imagine how this is one step removed from just being an anomalous pulmonary venous return. We've seen this. This has been called midline common osteum of the pulmonary veins in the literature.
And sometimes I've seen
I showed a case of that a couple years ago.
Yeah, it's not that super uncommon, but it's a weird appearance. It definitely catches your eye, but it's yeah, it's just a benign variant.
Oh. Cool. Yeah, one question we had was whether or not if there's focal absence of the pericardium in this region, if that could lead to this appearance. But it sounds like this has been described in entities where that was not present.
Yeah, I've seen this incidentally a couple times a year. You'll come across them.
Yeah,
I think,
one, maybe twice a year, once at least, seemingly incidental finding.
Oh, okay, cool. Well, that's all I have. Thanks for, thanks for, yeah.
Thanks for sharing. Seth, you want to go? You've been away for a while.
Yeah, sure. All right. I loaded these up the last time. I don't even remember what these are for. What I got these for. Okay, let me start off on, because I don't remember what this case is. Let's start on this case. Oh, this is an interesting case. So this was a guy who was sent to us from the glorious institution of UCSF with extensive detailed history and imaging from there. And it's just a weird case, and I don't have a good answer.
I've got this one in my queue to show, not today, but this is a freaking bizarre case.
You have this one to show? Yeah, this is really. Well, so these are all weird veno-venous collaterals. They're not AVMs. They all are veno-venous. You can follow them all around. They go from vein to vein. And he has this pronounced septal thickening, which is quite conspicuous. And again, all these veno-venous collaterals everywhere. And he underwent biopsy. So he's completely asymptomatic from my understanding. He has like no issues. And he underwent biopsy, and obviously UCSF has some pretty darn good pathologists, and they read this as PVOD. So, but it's not. So, well, it is. So pathologically, they thought it was PVOD. They said that these weird veno-venous collaterals have been reported in PVOD, although I looked up and I couldn't find anything in the literature about it, even though I trusted what they said. But he came here for evaluation for, because people with pulmonary hypertension get sent here. The issue is he doesn't have any pulmonary hypertension. His pulmonary pressures are completely normal. His diffusing capacity is completely normal, which is one of the most striking things you see with PVOD is that their diffusing capacity is awful. And except for his messed up lungs, he is physiologically normal. So the question is, what is this? And the answer is, we don't know. And I was going to raise this up for discussion because is it PVOD? Is it about the earliest form of PVOD that we'll see, but the guys will eventually become sick and symptomatic? Because you know, we were like, well, there's nothing to do with you in terms of intervention. We're not going to put, there's no transplant list because you're pretty much asymptomatic and your and all your pressures are normal. But, and it looks like, I mean, if someone showed me a case and put it in a book of PVOD, it sure would fit. Although I've not seen it with these venovenous collaterals, but we're talking, I have an N of now like 7 or 8 or maybe 10 of these cases. So thoughts, questions, comments?
Yeah, it's, well, just, so there was, this has been discussed multiple times here, and one of the pathologists said maybe PVOD, and then the other ones were like, well, it could be seen, but there was, like you said, there was nothing else to go along with PVOD. So yeah, nobody knows what this is. Originally, it had bbeen thought that they were arteriovenous malformations, but as you pointed out, they're not. You can't, you know, you can trace them all to veins, and they had a negative bubble study, and that was what.
Oh, I have the most beautiful pulmonary angiogram. I don't have time to pull it up. I totally forgot to download that. I had the most, so they did a direct catheter angio here because I do that in everybody. And it beautifully shows that are all venovenous connections, that they're not AVMs.
Can I give a suggestion?
And his saturation is normal, correct?
Saturation is normal. Albert wants to say.
And he doesn't have lung disease. I mean, he doesn't have a liver disease.
Not that I think of. I mean, he's literally a healthy guy who like runs marathons.
Yeah.
I wonder if he's got hemangiomas in his mouth or something like this, where there's some variant of, you know, some AVM sort of disease. But
no, but like HHT kind of thing, or
yeah,
but they're all venovenous though.
that's right.
And Albert, what were you going to say?
Yeah. So one thing that strikes me is it seems like it's involved in all lobes.
Sorry, we can't hear you.
Are we saying that it's really?
It only seems it predominantly involves the right lower lobe, so it is
And
possible.
left lower lobe.
Maybe a little bit left lobe. You may be catching it early enough that you don't have the clinical findings of diffusion capacity, all the other things that they may be looking for if it's sequestered in one lobe or another.
And that's what because we weren't sure if this would eventually turn into raging PVOD, and they're just going to follow them up with hemodynamic studies every year to basically see that it's not crumping, but it's just an odd case. And well, that's interesting to know that the pathology was not as definitive because, you know, in our reports, or actually from the UCSF reports, not the path reports, like the clinical reports, it said, you know, biopsy, underwent open lung biopsy, which is, you know, classic for PVOD. So they must have.
They were more of the like, this could be seen in PVOD, right? But then the clinical team latched onto that as a diagnosis because nobody else had anything better.
Yeah. So fascinating case, and
I've had it in my queue for months. I've just been waiting for any sort of follow-up.
Oh, sorry. Well, we followed it up and we followed it up and said it's not. Well, I'll send you the angios. The angios are actually really neat when you see the delayed filling on the venous side. I
didn't know if he had if he could have had some sort of pulmonary venous hypertension that led to this or what. I mean, it's just
weird. This is just a weird case. I'm not a bone guy. These bones are not normal. The lungs are not normal. So this guy's got, and he's got these bones that are quite abnormal all over the place. You see in the pelvis. So, and these, I have spine imaging, and it's, I don't know exactly what it is, but well, the bone people here back in the day, Resnick read this and said it was meliostosis. And the interesting thing is that the reason I'm showing you is not for that reason, but if you notice, you start to see adjacent to the ribs some of these little things here, and then I'll fast forward in time to a recent study where these have started to become these quite pronounced fibrofatty masses, and he underwent biopsy for these, and they just showed these weird fibrofatty masses. And we looked it up, and we were all excited because we found a case report describing that in melanocytosis, you can get these associated fibrofatty masses throughout the body. The only negative is that the case report was actually written by the people here and was specifically on this guy. So we're not sure if that N of 1 now is another N of 1. But it's just a weird case of melanocytosis with some weird pleural fibrofatty masses. Nothing special about this except that it's kind of odd.
But he also has some kind of lung disease and pleural
Oh
fluid.
yeah, no, he got sick. He developed like a DAD kind of picture that was, and it is interesting. He had multiple bouts of DAD. He was here with another bout of pneumonia / DAD. I can't remember what it was. That's how it came to. We saw the most recent one, and these fibrofatty things have been. He's here all the time, and he's been here for like 30 years. And these things have been slowly growing, but they've been biopsied because they're worried about liposarcoma, and it all came back as negative. But yeah, he does get sick. And then this is one of my guys were freaking out because they loved this case. To me, it was not as exciting because I was promised it was the triad, but it was in fact just a dyad, which I thought was very disappointing. But you can see here, there's this pulmonary calcified lesion. And then here are some gysts in the belly. And then there is some metastatic disease from the gysts in the liver. And this is Carney's dyad. I can't, so what is this one, a chordoma? I didn't remember what they are, to tell you the truth.
It's a hamartoma. They're supposed to have adrenal tumors, right? That's the triad.
That's the thing. There's no adrenal tumors, but she's had multiple of these things pulled out of her lung. I thought they're chondromas or chordomas. I thought they had another, maybe, like a weird.
Maybe chondroma, yeah.
Chondroma, yeah. They're benign tumors.
So she's had multiple of these things wedged out. You'll see wedge resection sutures all over the place. And she's had multiple pulmonary chondromas taken out and multiple just taken out, but she didn't have adrenal tumors. So thus she's sadly just a dyad. And actually, interestingly, when you call it what was the name? Do you remember the eponym? Yeah, it's like and so if it's a dyad, it's not Carney's triad, it's Carney's Stenonakis dyad. So just for fun. And lastly, this is a case where I just seen this 100 times now, and no one's ever written it up, and I don't know how to write it up with any sort of really prove it, because I don't know how you would do that. But and I'm sure you guys have all seen this, and we might have even talked about it in conference, where people have long-standing, basically chest ports in, or whatever you want to call it, metaports in, and they often sit against the right atrial wall and sit here against the right atrial wall, and you often see this soft tissue thickening that becomes thicker over time and eventually will calcify. And it's always in this location in the region of the crista. So you can see here, it's getting thicker and then thicker, and you can follow it out. And I have plenty of cases like this where it's not there before it starts. And then you start to see this thickening here, right along the crista, and then it starts to calcify. And then they get, someone notices it and they get an echo, and here it's more prominently calcified. And a patient gets listed as having a calcified thrombus or some sort of calcified tumor in their ventricle, when in fact, I think it's just some sort of irritation of the chest. You see here, nicely see the chest port going right into it, of either the mechanical irritation of the chest port staying in there long term, or specifically from the agents that they're injecting through there. And we see it all the time, and it's not reported in the literature. And I'm sure you guys have seen this, but it's just an interesting thing to nicely show that the change over time in the progression. Have you guys seen this before? Or?
Yeah, I've seen it a bunch of times, and I always thought it was chronically calcified thrombus. It seems like a lot of times when this is a great location for thrombus on ports.
Yeah, I mean, I think it's more than just, it might be thrombus, but I think it's some form of mechanical irritation, like injury to the actual right atrial endocardial layer because it's not.
Oh, I see, because you're seeing the fatty proliferation.
Well, it starts out as there's nothing there when they start, and then put the chest port there, and then obviously this thing is rubbing against it over and over and over again, And over time, you'll see the thrombus get bigger and then eventually start to calcify, or whatever this is, calcify. And then eventually when they often stop, they pull it out and there's just a calcified Goomba there. And I don't know. It's just never, and I've seen it, it's just highly associated with chest ports. I don't see it with any other catheters besides chest ports.
Seth, there almost looks like it's in the epicardial fat. I mean, or like it almost looks like a little contained pseudoaneurysm or something.
Yeah, let me go back to the sometimes
the way you have it oriented there.
Yeah,
like it was like a little mushroom extending out. I know it's a place we get a lot of motion, but
yeah, and that I think it's just poking against the radial wall. I think
as it calcifies, it sort of maintains that shape.
I think so, and and you know, I was trying to think about how's in here. You can kind of see now it's getting thicker and bulkier here, and I was like, how do you do this without having to review 10,000 cases? And that's probably the only way to do it, but in some sort of to show that it is happening. But here you can see it's just this little bit of calcification along the wall here.
Yeah,
and I think it's really along the wall, but I don't know.
I have not seen that, but I have to go look for it now.
Yeah, and I'm going to look at cases because I don't think I've noticed that before.
So I first noticed it at Maryland, and we were like, "What the heck?" And we just noticed a chest port there, and we saw it again. Then we saw it again, and then we go back and look at it, and before they had the chest port in, it wasn't there. And every single case that we had, it was specifically associated with. And I think here, honestly, I think this stuff. I think a lot of this is Krista that might have either. I don't know, but I agree what you're saying, Jeff. That here, there's a lot of. I think it's just poking and pushing through, but I'm not sure.
I guess that wall is so thin, if it's calcifying, it can sort of become fixed in that shape.
Yeah, but just look.
I'm gonna start looking for it now. But how long has this port been in? Do you know?
It was in. Let's see, about a year or two.
So this was just over 2 years that this progressed.
Yeah, and it was. And I thought I downloaded. I have a study before when there was nothing there. Before she got the port in, and it's one of these things we saw, and we were like, yeah, whatever. And then now I'm just seeing it. And I was looking up the literature, and I couldn't find anything about it. And the reason why it's now is that the last 2 times here, they've gotten like echoes, and then they got MRIs and all that stuff just for what is a just a calcified thrombus, basically.
Oh, cool. All right.
Anyways, those are my cases.
All right, David or Travis, any of you got cases?
I'll go since I've been gone for a while.
Sounds like a plan.
All right, start off with a radiograph, and I only have a PA view, and you can actually see if you cheat and look at the thumbnails on my screen where this is. But I just include this because it's the largest example of this that I've ever seen, and you see a mass, and I think that you can see a hilum overlay sign on both sides. You know it's not middle mediastinal, it's kind of spanning both sides. You know it's probably anterior, plus the aortic arch and the descending aorta are preserved. But this guy is going to go to surgery here, but this is just the largest goiter I've ever seen extending into the anterior mediastinum. And this patient is asymptomatic too. They're 73 years old. Now, usually I'm not a big fan of the 4T's differential because I think usually thyroid descends more along the paratracheal stripes anyway and often goes into the middle mediastinum, but this is clearly going into the anterior mediastinum. I mean, it's enormous. They haven't taken it out yet, but the other thing that was worth noting, and one of the reasons they did a repeat study, is they may embolize, because this is a little like either aneurysm or pseudoaneurysm supplying this thing, probably just aneurysm from one of the branches of the thyrocervical trunk on the right. But you can just see how tortuous and big these vessels are. But I don't even know why they're going to take it out, just probably because they found it. The patient's asymptomatic. But even on the non-contrast, you can see it looks like thyroid because you've got some higher attenuation iodine and such in it. But
definitely
just more of a
AFIP.
What's that?
I said I'm definitely stealing that for my AFIP lecture. That's a
please, yeah.
that's
a whopper.
That's a whopper. I've not seen that big.
Yeah. Now here's one that I've seen once before, and I showed it, and I can't remember if other people have shown this as well. This is another This is one of the rare birds, but this is a 33-year-old woman who presented with hemoptysis. You can see she's got a little bit of, presumably this is the hemorrhage surrounding this lesion, but it's a well circumscribed 3 to 4 centimeter thing, heterogeneously enhancing in her right lower lobe. And of course, I think we most commonly think about as a carcinoid in a patient of this age, but you can see this is not arising from an airway. It's just more displacing things out of the airways. It was a little hot on the PET. Let's see. I mean, it was like SUV of 4 or 5 or something. But they plucked this one out. And this happens to be something that we see in this demographic in particular. This is the second case of a pneumocytoma or sclerosing hemangioma that I've seen now. And so the old term, I guess, is sclerosing hemangioma, and maybe, Seth, you have more insight from AFIP, but now they call these pneumocytomas. But it's a pretty typical appearance of an atypical tumor that is well circumscribed. They're usually in younger to middle-aged females, kind of heterogeneously enhancing there. And I included a recent whatever pathology journal this is, Diagnostic Cytopathology, is just talking about how it's usually in middle-aged females.
Yeah, that's very interesting. So now that we have immunohistochemistry, they found evidence for the epithelial origin. So the EMA was positive, right? Epithelial membrane antigen.
Oh, let's see. Yes. So wait, what do you know about that, Howard?
Just in the sense that there are no antigens on the cell surface of vascular lesions, but rather the pneumocytoma is related in part to if it's EMA positive and negative for any of the others like CD34. That's additional evidence that it's not of vascular origin, even though it used to be called sclerosing hemangioma. Yeah.
So what is it arising from? What is it a tumor of?
From the cells lining the alveoli. Now, I don't know about the EMA reference to type 1 or type 2 pneumocytes, but I think these now typically are EMA positive now that we have that immunohistochemistry we can do, and that points to that particular entity. EMA positive nodule. Yep.
Yeah, and this one was EMA. I don't know if this talks about it, but I think one thing just that even in this case, they did a bronch first, and the frozen path on the bronch was thinking it might be an adenocarcinoma. And this article talks about how these can be mistaken for adenocarcinomas. They have at least for us, what seems like a pretty obvious table where they talk about the radiologic findings of adenocarcinoma versus these. But yeah, so this is the second one. So I've just to revisit. This is the one that I showed several years ago now. It's one of my early cases from Emory. Similar young middle-aged woman nodule here. I don't remember if she came in with hemoptysis or not, but you'll see it's a pretty similar look, a little bit smaller tumor in the lingula, maybe a little bit of surrounding ground glass, but kind of a similar heterogeneous, slightly hypervascular look to it. So this was the other pneumocytoma or sclerosing hemangioma. Yeah, there you go, Howard. There's your positive EMA.
Yeah, there you go. Interesting.
So,
yeah.
So young to middle-aged women, well-defined, not arising from an airway as a carcinoid would.
So is it
on the differential? No, it's a benign. It's a benign tumor.
I'm looking at this Chinese article that has 76 cases or something, and it's the imaging that on the CT, and every single case looks exactly like the case that you showed. It's like low density in the center.
Yeah.
Peripheral rim and kind of a peripheral rim enhancement or calcification. That's interesting.
You don't have any of the, or you've got to have some of those at the AFIP.
Oh, I'm sure we do. I don't do the rare tumor stuff.
Okay.
So we do get them sent in, but yeah.
And then I'll just show this one. This is for David, and if Sudhakar is there, because I know this was something they wanted, that Sudhakar in particular wanted on the radar, and I know David has shown a case. 65-year-old woman, history of epilepsy, and that was it. Went to an outside hospital, had this CT early February, and you can see she's got a little bit of perilobular stuff at the lung bases. You might just say that this is atelectasis in this case, but of course you could have a little bit of organizing pneumonia and kind of a perilobular distribution. She wasn't doing all that great at this time, but she got severely worse over the course of a month and a half. And now when she came to us, you can see that she has more, definite perilobular consolidation in the lower lobes, and a little bit in the upper lobes as well, a little bit of traction, some ground glass, kind of looks like just different phases of organizing pneumonia, organizing lung injury. So she didn't have any history of drugs or connective tissue disease or anything, but we told them to be on the lookout for myositis, because certainly some sort of connective tissue disease could present like this. And she went downhill relatively rapidly after this. She was intubated within a couple of days of that CT. And then unfortunately, this was the last radiograph that they got of her. And about this time, they got the panels back, and she was MDA5 positive. So didn't have any myositis, but this is an amyopathic dermatomyositis with MDA5, which of course can be associated with fulminant respiratory failure, as was in her case. She passed away a couple days ago. And so it just looks kind of like organized pneumonia. And I suspect this is one of those ones that probably we would have used to call AIP, but now that we have some of these markers, you can see, and that's why we always have to think about myositis and connective tissue disease as a presentation of acute lung injury.
Wow.
So,
yeah.
But I will stop there, because David, I think you showed one like a couple of years ago, which was the first time I had seen that. And I know Sudhakar was asking recently for collections of these, and we've only recently started adding this to the myositis panel.
Right. So we had two cases of roughly 30-year-old women who presented within a couple of months of each other and had this rapid downhill pattern with organizing pneumonia or NSIP pattern, but it just galloped. It galloped week to week, really striking. And they both had MDA5 disease.
All right, that's it for me for today, Jeff.
David, do you have cases?
I have a couple.
All righty.
And nobody can see you scream, but can you see my screen?
Yep.
Okay. So this person presents with this big mass here, which turns out to be anterior here on this outside radiograph, very sharply defined posterior margin to it, implying that it might be arising outside the lung rather than in the lung, with such a nice envelope around it. And a CT scan around that time shows probably what you were expecting. It's really a chest wall lesion with destruction of the anterior rib at its cartilaginous portion here, and speckled calcifications within it. So this is a classic chondrosarcoma in this, I think, 61-year-old woman. So a nice example of chondrosarcoma with findings of an extra pulmonary mass anteriorly. Nothing too unusual about that. And then here's a man who has very low lung volume here and basal atelectasis, and he's looked like this since at least 2014. Really low volume. Notice his shoulder and humerus is osteopenic. And this is what his CT scan looks like. He's got pretty scrawny pectoral muscles, and follow his paraspinal muscles downward. There's a lot of fatty infiltration of paraspinal muscles. Then we get down into the abdomen, and I'll show you an abdominal CT in a second. Well, let me show you right now. Here's his abdominal CT, because these paraspinal muscles pretty much disappear down here, just completely fatty replaced. And then he's got this thinning of the crura on both sides here. So this fellow has a Becker muscular dystrophy. I need to look that up and clarify that. But this is a case, I think that has diaphragm muscle involvement, given the speckling of the crus here. This is also fatty infiltration of the crus muscle here. So thinning and the speckling, indicating that his muscular disease is affecting his diaphragm. I think that is a good reason for him to have the very low lung volume here. So we look at his crus here, you can see how thin the crus is, particularly here on the left. And it's thin here on the right as well. Okay, so another diaphragm case, in this case, muscular dystrophy.
Did he have normal heart function, or did he have thinning of his myocardium? Looks pretty good there.
Yeah, it does. Let's go back to the cross section and just look at the heart here. So his heart size is normal, and it looks as if he's got a decent thickness to his septum, at least there. So I think, you know, based on normal heart size here and this, he probably doesn't have cardiac involvement. Do you know anything about the Becker muscular dystrophy? Does it typically spare heart or something?
I don't know, but I think it's one of the milder ones. He was how old?
I think he's in his 40s, but I'll clarify that.
That would be.
You can get. I know you can get cardiomyopathy in Becker. I don't know if it's the same incidence as Duchenne or not.
Mm-hmm.
We've had a few cases of it in the last few months, and they I don't know if they necessarily get thinning, but they can get myocardial fibrosis, which you can see on post-GAD images or T1 mapping, and then they'll have an abnormal strain pattern on tagged left ventricle views. But that's usually a late finding in the disease.
Okay. All right, gentlemen, those are my two cases.
All right, thank you, David. All right, well, I've got about 4. Let's see what we got here. So this is a fun case. I'll start with the radiograph. It will load. Okay, maybe not. There we go. Okay, here's the radiograph. Oops, it's misbehaving here. Let's try again. There we go. So on this radiograph, we can see there's this abnormality in the right upper lung, this tubular-shaped thing heading towards the hilum. And you can see there's a paucity of vessels and a hyperlucency in this area. So you could think a obstructed airway or a vascular anomaly. And this is a twofer case. So we've got, we'll come to the left. You can see there's a nice example of bronchial atresia in the left upper lobe. And this is an interesting case because this involves the entire apical segment. And you get this very large bronchocele and mucocele. The lung around it looks relatively normal, although there are a few little holes up there, but there may be emphysema because this patient also happens to have a adenocarcinoma on the other side. What else I thought was really cool is I have a VQ scan, and you can see this really nice lobar or like segmental match defect because, of course, because there's no ventilation, there's going to be reduced perfusion. You can see there's no ventilation to that segment in the right upper lobe there. And then, of course, there's going to be a VQ match, so there won't be perfusion there. And then this is just his post-resection. So it is cancer taken out. But on this one, you wonder if there is a little bit of just abnormal lung there, if this is like a hybrid lesion with some CPAM features, or if it's just some emphysema. But you don't really see anything else, emphysema elsewhere in the lung. So I wonder if that's what it is. I think he's got another cancer brewing here as well. So just a really extensive bronchial atresia with 1 and probably now 2 lung cancers. All right, Howard, you're going to like this case. This is a patient with a history of a pleomorphic sarcoma. And, oh boy, I don't know what's going on here. My things won't load. Okay, Osiris is really being... Let's see if I can get anything. There we go. I'm not sure why it's doing that. And so this was an earlier scan, and we for metastasis hunt, and there were a few little nodules at that time, but not much else going on. Now we jump ahead 4 months. This is the new scan, and all of a sudden, as we look through it, we'll start seeing there's a little cystic lesion. There we go, the left upper lobe there. That was new, and then there's another one here. A little more inferiorly, it's got some ground glass opacity around it. And then as you keep looking again, more of these cystic lesions are popping up. And then, of course, the solid nodules. So these are new cysts and new nodules and some of the sarcomas. So these are cystic metastases. There's another one down here.
Oy.
And we've seen several examples in sarcomas, in colon cancers, and a few other types of cancers. So I still don't fully understand the mechanism. If it must be some kind of small airway obstruction. This one, you wonder if maybe cavitated. It's got a thicker wall, but yeah, new cysts, got to be careful with them, especially because you see these have a little ground glass around them, so I don't know what that's about. But
Jeff, there wasn't any chemotherapy going on in this person that might have caused necrosis in these lesions and
not
cavity.
to my knowledge, because they were on surveillance.
Uh-huh.
But the next scan will have chemotherapy, is my guess, because now we have new metastases. So, but yeah, that's a good thought too. All right, here's another cancer case. So this is an interesting case. So this is a 57-year-old male who presented with hip pain initially, and you can see there's this sclerotic lesion in the right femur. He's had a herniorrhaphy in the past. He also has this sclerosis of his acetabulum area there, and so he was worked up. He's a never smoker and was found to have metastatic lung adenocarcinoma. So that was his initial presentation, and this is several months later. And when they further work up, he has all these little Cheerios that almost, at first you might think are Langerhans cell histiocytosis until you realize A, he's a never smoker, and B, he's got this ugly necrotic mass in the left upper lobe. Now, we've seen this disseminated adenocarcinoma before, and when I see this pattern, one of the things I think about is the EGFR mutation, which is more common in never smokers and females and East Asians. Interestingly, though, he did not have the EGFR, but he had a mutation I never heard of before. It's the RET, which occurs in like 1 to 2% of adenocarcinomas. But I was reading about it because I had to figure out what it was, and I still can't remember what it stands for. One of these genetic things, but it is associated with, and you see he's got bone mets everywhere. It's associated with never smokers or minimal smokers, and it's associated with dissemination, particularly in lungs and bone. But it's another example of Cheerios, and these in case are not Langerhans, but rather adenocarcinoma metastases that's just everywhere. And he didn't have the lymph node involvement, so I don't know how much of this is airway spread, but there's clearly some lymphatic nodules as well. But just a very weird case of lung cancer. I don't know if any of you ever seen a RET positive adenocarcinoma.
They talk about it at our tumor boards, honestly.
There's
but I don't.
Yeah, the targeted treatment I'm aware of is some clinical trial drug that has some long alphabet soup name, but that targets this pathway. All right, now this one is kind of an interesting case. I'm curious at what you guys think. So this is a patient with well-controlled HIV and was told she had sarcoidosis. This is an old scan. It's coming for another opinion. But you can see the radiograph is very abnormal. There's tiny little nodules or irregular opacities. And when we look at the CT, we can see that indeed there are a bunch of small nodules that I don't think anyone would argue against sarcoid. And along the airways, we see some bronchial dilation, maybe some traction bronchiectasis, but some cystic spaces. And I have no issue with that for sarcoid. I still think this is all going to be sarcoid. But as you come down a little bit, the middle lobe and the lingula look a little stranger. There's more ground glass opacity, and then there's almost confluent cystic spaces. Kind of looks like not really, it's not honeycombing. I mean, there's no, I think you can see why it'd be called that. I mean, there's an airway going through that, but just sort of this weird confluent cystic spaces, and then all these ground glass nodules. And I don't have any other imaging, and I think I can just call this all sarcoid. I know I've sometimes seen these funny cystic spaces, or is there something superimposed like an LIP type pattern, which may account for some of these smudgier nodules and some of these holes related to HIV. But as far as I know, the HIV is well controlled with the standard therapy and stuff like that. So I don't know. Have you guys ever seen sarcoid with this kind of degree of cystic type spaces?
That's odd.
Not in memory.
Yeah. Like the stuff up here, I've seen this, and it may just be a little airway distorted.
Agreed. The stuff along the bronchovascular bundles in the upper lobes we've seen on occasion. Yeah, the right middle lobe and lingula.
She's not a smoker, and she's not a.
Not that we know of. Let me look at this. This kind of just really strange.
Yeah, it's weird.
Yeah, I think she's, yeah, we'll get some follow-up on her, at least some clinical evaluation, but,
You know, Jeff,
yeah,
sarcoid is one of the causes of bubbly lung disease where you get what you want to call honeycombing, but it's often in a strange distribution. It can
right.
be along the fissures in the mid lungs, rather than at the bases and stuff like that.
Mm-hmm.
And I'm just wondering if this is going to be the sort of sarcoid that leads to that ultimately, where these cystic spaces get bigger and the walls get thinner. So this may be, just part of that spectrum of advanced sarcoid.
Yeah, yeah, and the fact she has sarcoid makes the fact she's a smoker much less likely.
Yeah.
So yeah, that's kind of what I thought, because I've seen sarcoid, and it's in some of the older texts and papers they put it in the differential for honeycombing, but the stuff you see in sarcoid, like you said, is more central, or it's in weird distributions. Some of it may be airways, some of it may just be around airways, like a lot of this stuff. But yeah, it's just funny how it's almost stuck right here, but it's on both sides. It's not like the sequela of an old infection, because if we go to the other side, you see the same thing, although it's less exuberant. It's the same thing in the middle lobe here. You see it, the sort of cystic spaces inferiorly. But my feeling is this is just probably all sarcoid related. It doesn't even look like all pneumocystis given its distribution.
Tan Muhammad showed a spectacular case of that bubbly lung disease in sarcoid.
Okay. Well, that is all I have this week, so I think we are done.
Okay.
Thank you, everybody.
Thank you. Great cases, everyone. Thank you.
Thank you.
Thanks.
Next week.
Take care.
Bye.
Bye-bye.
Bye-bye.
See you next